Now, the evaluation of treatments for heart disease has to be evidence-based. And what I presented to you is evidence-based medicine. But in emerging more recently and increasingly, we are talking about value-based medicine. And this is particularly true for the government hospitals, the public hospitals, for the medical insurance companies, for those who have medical insurance. They are increasingly looking at value-based medicine because in a country where the resources are limited, although there's a lot of funds in the government, but it's fair to say that the funding is limited, then there has to be some way to distribute the funding to the right sort of treatment. So if you have a particular treatment which costs a lot of money versus another treatment which is very cheap, but is able to treat a lot of people, then often the policymakers have to come up with some way to determine how to use the resources. So unfortunately, a lot of the newer treatments are very, very expensive. So the TAVI valve, for example, costs about 10 times the price of the conventional aortic valve. So this has an impact on developing countries like Malaysia in how to provide these newer treatments for the population because the cost is so high. And as you can see from the studies, if the cost is very high, but the impact is very great, that means it's a lot better and more effective than conventional treatments, then of course there's a strong argument to just use this more expensive treatment. But if the benefit is marginal, if you're looking at survival and quality of life, and you can see that in the long term, the two treatments are similar, but it is just that one treatment allows you to recover more quickly from the procedure, then the policymakers have a bit of difficulty in justifying the allocation of funds to this new treatment. And this is the case with the TAVI valve. There is some difficulty getting it to be widely used, particularly in the public hospitals, because of the cost and because the benefits do not seem to be there unless the patient is really unfit for surgery. And this is where the differences come in, probably in the when we compare the better off Western countries where there are more funds versus the developing countries. So there's a bit of divergence in the use of the TAVI valve in Europe versus Asia. So we have gone through the aorta and the aortic valve. I hope you're all still with me. It's not too complicated. So we come now to another valve here. This is the mitral valve. The mitral valve separates the heart from the lungs, essentially. So you have got the lungs here. The lungs, blood from the lungs. So blood has to go through the lungs. The lung oxygenates the blood. So the body, of course, needs oxygen. All the cells, all the organs need oxygen. So it goes through the lung. The blood gets the oxygen. It's enriched with oxygen. Then it returns to the heart, to this chamber. This chamber pumps, the blood goes into this other chamber. When this chamber pumps, the blood leaves the heart through the aorta. And then this valve here, called the mitral valve, has to close to prevent the blood leaking into the lungs. So this valve also can get faulty. It can start to leak. And if that happens, then blood would then leak into the lungs. So the patients typically feel short of breath because the lungs get congested due to a leaking mitral valve. So the mitral valve can leak because it may be defective with age. The mitral valve is essentially like two doors which open and close. So these two doors need to close at exactly the right place to meet each other. And then these two valves have got supporting structures to the heart chamber. So sometimes this supporting structure can tear. If it doesn't tear, it can elongate, it can get longer than normal. And so these two doors don't meet each other, and then you get a leaking heart valve. Or sometimes the heart valve may get too big. So when it's too big, when they close, they don't close properly. There are some gaps in between, and blood can start leaking. So this is a structural problem with the heart valve, and they can result in symptoms, shortness of breath. The only way to treat this is by surgery, because it is a mechanical problem. Medication can help the patient to feel better in the terms that it can relieve some of the congestion in the lungs, but it doesn't solve the problem. So the only way to solve the problem is to fix the valve. It's just like when you have a leaking pipe, you have to fix the leak. And the data now shows that the earlier the leak is fixed in the valve, the better the patient will do in the long term. So this is the survivor of the patient, how many percent are surviving, and this is the number of years after the surgery. And you can see if the patients have surgery when they have no symptoms, when they go for a medical checkup, and the doctor hears what we call a murmur, or you can actually hear a leaking valve just by using a stethoscope. Many patients, in fact, hear it themselves. At night, when it's quiet, some of the patients or their partners tell them they can hear a sound from them, and that is because the heart valve is leaking. So in those patients, if they seek treatment early, you can see they will live the longest after surgery. If they wait until they have symptoms, they still do very well, but they do not live quite as long as those who have surgery when they have no symptoms. Those who wait until they've got very bad symptoms before going for treatment, they still do better, but they would have done better if the disease had been treated earlier before they developed symptoms. And this because the longer you wait, the more strain it puts on the heart, and the heart will get bigger, and as the heart gets bigger, it gets weaker, and if it's left for too long, what we call fibrosis sets in. So the normal heart muscle is replaced by fibrous tissue, which is non-functional. So the earlier we fix the leak and reverse the problem with the heart, the better it is for the patient. And of course, the risk of surgery is a lot lower as well, the earlier we intervene on the heart. And of course, with this condition, we now know that it's better to repair the valve. These again are survivor curves. The solid line are those who have the valve repair. This is the survivor, and this is the number of years after the procedure. And this dotted line is the expected survivor in the normal population. So you can see that those who have the valve repair, their survival is actually the same as the normal population. So actually we are able to restore their life expectancy back to normal, meaning they will lead a normal life with a normal life expectancy once we fix the leaking mitral valve, provided they have had the surgery earlier enough before any damage has been done on the heart. But sometimes it's not possible to repair the mitral valve. Sometimes we have to replace it. That is second best because of the limitations with the artificial heart valve. As I mentioned earlier, we don't have an ideal heart valve. One is tissue with limitations, another is mechanical, which has its limitations. So they still do better with valve replacement, but they will live longer if we're able to repair the valve. So these are some of the techniques which have emerged to repair the mitral valve. This is some new cords which are being sutured to the heart muscle, and this is to the mitral leaflet. And so these are new material. These are actually Gore-Tex. Gore-Tex is a very strong material which is very smooth. Gore-Tex is also used in clothes. It's a very strong material, and this is what we use to replace the torn cords. And sometimes if the valve has got too big, then we can reshape the valve to its normal size and geometry so that it will close adequately. And along with that, new rings have come up. This is like the door frame. So we can fix the door to the right size and shape and the hinges to make sure it closes. But also we almost always suture in a new frame to support the valve so that it doesn't get any bigger. So this, and over the years, newer what we call rings or annuloplasty rings have emerged, which have also improved the results of surgery. Now, the mitral valve can also be pulled apart by the failing heart. So in some patients, the valve is actually normal, but you can see that the valve is attached to the heart muscle. And sometimes patients develop a weak heart. And this could be due to a coronary disease. If they have a heart attack here, for example, this part of the heart muscle may get weak and start dilating, and that will pull the heart muscle apart. Or there can be other causes for a weak heart, like in dilated cardiomyopathy. So in this condition, you can see that the valve leaflets are normal, but it's being pulled apart by the weak heart. So in this particular condition, because the primary problem is not with the valve, but with the heart muscle and the ventricle, most of the time we would treat these patients with medications first. And nowadays we have got very effective medications, particularly in the last 5 years, some very effective treatments for heart failure have emerged, where we've really made a difference in being able to improve the function of the weak heart. And with that, we are able to also reduce the leaking heart valve. So in this particular type of leaking mitral valves due to heart failure, we often do not need to do any surgery, and taking medication is usually good enough for a lot of these patients. But of course, it has to be, we have to interrupt this cycle early, because what happens if the leak is very bad already, then that can prevent the medications from working. So sometimes, unfortunately, the condition presents a bit late, and we treat them with all the medical treatment, all the tablets, and there are at least 3 to 4 different types of heart failure medications we can give. The presence of a very bad leak in the mitral valve prevents the medications from working. So those patients, if after 6 months of medical treatment, they still have this very bad leak of the mitral valve, and the heart is still weak, then we may need to do some surgery to stop the leak and allow the medications to work better. So this is this is one of the trials we did. This is looking at moderate leak. So we know for sure that if you have got a very bad leak of the mitral valve, you would need some procedure to stop that leak. What we didn't know was if the leak is only moderate in severity, it's not very bad, and if the patient needs surgery for the coronary disease. So if the patients are going for bypass surgery and they have got a moderate leakage of the mitral valve, should we repair the mitral valve at the same time? So at the time, this was when I was in London in about 2010. The study was published in 2012, but the study itself was done much earlier. One of the things to appreciate with any publication you read is it is always a few years old, because it takes some time to do the research and then to present the results and then to publish the paper. And a lot of the times when the journal, Circulation is one of the top cardiology journals, when it accepts the paper, there's always a lag between them accepting the paper and then publishing the paper. So by the time the paper is published, it is usually a few years old already. It's usually a few years after you have presented the results in the scientific meetings, or after the results have been discussed at scientific meetings. The exception to this is, of course, I think Dr. Kam already mentioned COVID earlier at the start. The exception of this is COVID, because COVID has been has had such a major impact on global health worldwide, and has been declared a pandemic. All the journals have accelerated publication of the results. So all the research of COVID has come up very, very quickly. In fact, the moment the results are known, it is actually published as what we call a preprint. So even the journals, when they don't publish it in their journal, they already publish the papers online on the internet. So that it's already available to everyone. And this is to allow as many scientists, as many doctors as possible to look at the results, learn from the results, and then come up with their own new research as well. And that's how the treatments and the knowledge for COVID, which is a new disease, has emerged so quickly. It has only been around for a few years, and already we have vaccines, we have treatments for it, and we know so much of it. It's because of this accelerated publication of scientific data, which is a good thing. If it can be applied to all the other conditions, I think medicine will progress a lot quicker, you know, if we have this sort of accelerated dissemination of information for all the medical conditions. But conventionally, publication of medical data takes some time. So this is one of the publications. So we did a randomized trial essentially. So patients going for bypass surgery who had moderate leads of the mitral valve, we assigned them at random. Half a group, they would just have the bypass surgery. The other valve, the other half, they would have the valve repaired in addition. And this was done in 7 centers in the UK. These are the age group of the patients. And one of the things we look at was the patient's exercise capacity, which we measured by this parameter called peak oxygen consumption. So we can see that those who have surgery and the valve intervention, their peak oxygen consumption was a lot higher compared to those who just had bypass surgery. So that means patients who had the valve repair did a lot better than those who just had the bypass surgery. And also the leakage of the mitral valve decreased a lot more compared to those who just had bypass surgery. And this BNP level is a marker of heart failure. They also reduced a lot more in those who had the valve repair. So we knew from this study that it is beneficial to also repair the mitral valve in addition to doing bypass surgery in this group of patients. Now, with the mitral valve, we have also got this newer treatment called a transcatheter intervention, where again, we don't have to do open surgery to repair this leak. We can go through a big vein in the groin, and then we can put these devices, we can go into this heart chamber, we can puncture a hole in this wall which separates 2 of the heart chambers, and then we can go to the mitral valve. This is the mitral valve here, and then we can then deploy this clip. This clip essentially clips the 2 leaflets of the mitral valve together, as in here. And then by doing it this way, reduce the leak of the valve. Now, this technique will work in some cases, not all cases, but some cases of a leaking mitral valve would work very well with this technique. And the good thing with this technique is, again, it doesn't involve open surgery. It's just a little cut in the groin. So the recovery is a lot quicker. Only after a few days, the patient is completely recovered. But it doesn't work in all patients. And to evaluate this treatment, the proper trials have been done. So again, how the trials are done, you have a group of patients with this condition, and you randomly assign them what we call a randomized controlled trial to either having this new treatment or to conventional surgery. And then we follow them up over a few years to see how they are doing. So in this case, we look at the freedom from death, mitral valve surgery or reoperation. And the ones in red is those who have surgery. So freedom, that means you're free from death. So the higher, the better. So you can see those who have surgery, they have greater freedom. That means less of them were dying and less of them needed re-intervention. Compared to those who needed the device, who had the device, those who had the device, the mitral clip device, they had lower freedom from death. So more of them, unfortunately, were dying or having a repeat intervention compared to conventional surgery. So again, with this treatment, it is recommended for those who are not fit for surgery because it is still better than just taking medication. But for those who are fit for surgery, then surgery is still the recommended treatment because it will help them to live longer, free from any interventions. But compared to medication, this treatment is better. So this is from another trial, and the ones in blue are those who had the mitral clip, and the dotted lines are those who had medications alone. Now this data is a bit presented a little bit differently. So this is presented as, say, as heart failure hospitalization, number of patients needing hospitalization for heart failure. So the lower, the better in this study. So you can see the blue lines are lower. So less of those who had the mitral clip were going into hospital compared to those who were just taking medication. And similarly, this is all-cause mortality. So again, lower the better. So less of these patients needing receiving this intervention were dying compared to those who were just taking medication. So it's still better compared to just taking medication. But if they are fit enough to have surgery, then surgery is still the better option. So the very last thing I should probably cover, because I think this is probably the most common cause of disease in the heart disease in the country, that's coronary artery disease. And the blood is a pump with any organ. The blood needs its own blood supply, and the blood is supplied. The heart is supplied by coronary arteries, which brings blood to the heart. And these coronary arteries can get disease through plaques, typically due to cholesterol or other genetic causes. And the buildup of these plaques would narrow what we call the lumen, so narrow the coronary arteries. So blood will find it difficult to flow through the heart, to flow through the coronary arteries to the heart. And this can cause symptoms of chest discomfort. If it blocks off completely, then you can have a heart attack. So this is a coronary angiogram. The black thing is the coronary arteries, and they should all be this size. You can see part of it is very narrowed, here, 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 and part of it, you see there's no blood going through. So this patient has got what we call multi-vessel coronary artery disease. That means blockages or narrowings in several places, So various treatments are available, medications, angioplasty or stenting, or coronary artery bypass surgery. All of these patients will need medications. So regardless of the severity of the condition, everyone would need medication. And there's various medications, depending on the severity, depending on the condition. Patients may be put on some of these medications. So there are the blood thinning medications like aspirin, clopidogrel, or ticagrelor. There are the medications which relaxes the coronary arteries so that blood flow is improved, like the nitrates, the calcium antagonists, trimetazidine. Then there are the medications which help the patient to live longer, such as the beta blockers, the ACE inhibitors, the ARB blockers. And then there are the medications which help the patient to live longer and also help to stabilize all these plaques. And these are the statins, the acetamide, the fenofibrates. So various class of medications acting on different properties which cause this coronary artery disease. And then the stents, if the coronary disease are very bad, then medications may not be sufficient, particularly if you have had a heart attack. So in the acute situation, if you're having unstable angina or having a heart attack, then stents are the best treatment because they will straight away open up the blood vessel and allow blood to flow through. In more stable patients, if you're taking medications and still getting chest pain or shortness of breath, then stenting is also a good option. And the stents essentially pushes open the narrow arteries. So essentially, this method is deployed inside the coronary arteries. When it's deployed and open up, it allows the blood to flow through to the heart. And then, of course, a more extensive disease, like the example we just showed, where there's multiple blockages, multiple narrowings, then bypass surgery is the best treatment. Because if you put in stents, which technically can be done, but unfortunately, when the disease is so extensive, they don't tend to last very long. So bypass surgery is best. And essentially, these are like building a new road to bypass all the old roads, or building a new highway to bypass the old roads. So a blood vessel is taken from under the chest wall. One end of this vessel is still attached to this artery, and the other end is attached to the heart. So then blood flows out into this artery, through this new artery and to the heart. So this bypasses all the blocked arteries here. So the front part of this coronary arteries is just like the highway. Blood just needs to go through it, and the blood needs to reach the town, which is this area. So by doing a bypass graft, we bypass all the narrow arteries so that blood is able to reach the town. Then we can also take blood vessel from the arm, what we call the radial artery, or from the leg. And one end is stitched to the aorta, the other end is stitched to the heart. So this then bypasses the blockages. So this is the best treatment for multivessel coronary artery disease. So the stents that treat the culprit lesion, but it does not protect against future lesions. So you have a stent here, but if a new lesion develops either before the stent or after the stent, then the blood flow to the heart will again be interrupted, and then you will need to have another stent put in. Whereas in bypass, it works a bit differently because the whole at-risk area is bypassed. Even if new disease develops, it doesn't matter because the whole area is bypassed. Blood will just flow through the new artery. Even if the original artery blocks off completely, it wouldn't matter because you now have a new way to bring blood to the heart. So there is a bit of difference between these two interventions. Now the trials have been done with bypass surgery, as with all other interventions, and these are proper clinical trials comparing the two groups in multivessel disease. So in this particular study, the Syntax trial, which is looking at 10 years after the intervention, and this is probability of death. So the lower, the better, obviously. The lines in red is PCI, percutaneous coronary intervention, those who have stents, and the ones in blue are those who have bypass surgery. You can see that over 10 years, those who have bypass surgery have a lower probability of death. So they have less chance of dying compared to those who have stents. And this is those with multivessel coronary artery disease. So for those with one or two lesions, stenting is by far the better treatment. But if you have extensive disease involving multiple arteries, then bypass surgery will give you the best survival. And this is another study. This is looking at diabetic patients over 5 years. And this is looking at cumulative mortality. So how many patients are dying? And the lines in blue are those who have bypassed, the ones in red, PCI or stents. So you can see that those who have bypassed do better. Less of them are dying at 5 years compared to those who have stents. So the data is there, and we are able to tailor the treatment for individual patients. But of course, it's important to, I point out at the beginning, to look at individual patients. So if you look at this curve more carefully, you can see in the first year, there is no difference between the two treatments. Stents and bypass are the same. And perhaps the risk of surgery is a little bit higher compared to stents in the first year. Then after the first year, the survival curves separate in favor of surgery. So that's why in the older patients, say if you're in the 80s, they may not live long enough to see the benefit of surgery. So in those patients, even if they have multi-vessel disease, stenting may be advisable because they may not see the benefits of bypass surgery. But if the patient are younger, in their 70s or 60s or even younger, then bypass surgery is definitely advisable because the risk for surgery is very low in this patient. And at the same time, the benefits are very high compared to stents. Of course, we have got 80-year-olds who will live up to 96, like our previous Prime Minister. He actually had bypass surgery when he was in his 80s. So it's sometimes difficult to generalize, and we have to individualize for each individual patient. So that's the end of my presentation. I hope that was useful. I think effective treatments are available for all forms of heart disease. These are tailored to each individual patient depending on their condition and needs. In addition to evidence and value-based considerations, patient considerations are also important. So nowadays we always ask the patient what is most important to them, and then we can tailor the treatment accordingly to the patient. So thank you very much again to the British Graduates Association of Malaysia for inviting me. I hope I've not taken too long. I just realized that I probably have overrun a bit, but I'm very pleased to answer any questions from the group. Thank you.